This is the Garrison Lecture for 2022. This is an audio and video accessible version. It is captioned, and I will be reading descriptions of the images. Since I cannot take questions, there's a brief coda in which I describe how I came to do this work and acknowledge some of the people who inspired me along the way. This is image 1. It says syphilis 1880 to 1917, patients, disability, history, and it has my name, Janet Golden. My presentation today builds on the work of so many historians, and for reasons of time, I cannot acknowledge them, you, all by name. Rest assured, I cite you, I've learned from you. Before I begin, I want to note this is a pandemic-restricted talk. My research, like your research, was interrupted by a virus and by archive closures still in effect. Much of which I'm presenting today comes from an ongoing investigation. I'll be talking about working-class Philadelphians diagnosed with tertiary syphilis, more specifically locomotor ataxia, from 1878 to 1917. This image says locomotor ataxia, an inability to control bodily movements, particularly gait, and a common condition in late-stage syphilis. There is an image showing 3 men, 2 leaning on canes, 1 in a chair, and it says, "How does syphilis affect the spinal cord?" I draw from 2 sets of incomplete records. First, from the neurology dispensary of the Hospital of the University of Pennsylvania, HUP, from 1878 to 1889. And second, from 3 locomotor ataxia casebooks from the Philadelphia Orthopedic Hospital and Infirmary for Nervous Diseases, or what I'll call POH, from 1894 to 1917. This image says syphilis and disability, goals. Expand narratives of ordinary people coping with syphilis, uncover the lived experience of late-stage syphilis and its multiple manifestations as a chronic painful condition, complicate the medical history of syphilis. We have many accounts of syphilis in different individuals who were treated surreptitiously, and we know about people with syphilis from studies of Tuskegee when treatment was denied. But we know very little about ordinary urban women and men coping with late-stage disease around the turn of the 20th century. Syphilis, with its multiple manifestations, required these individuals to abandon their previous sense of themselves and to cope with a chronic, painful, worsening, and sometimes life-threatening condition. Disability history has given us many accounts of individuals living with impairments arising from their physical conditions and the social and cultural responses to them. Yet people with syphilis are not found in these narratives. I address that omission by briefly scrutinizing social norms that define people with syphilis as disabled morally as well as physically. I seek to illuminate how the diagnosis, as well as disease symptoms and progression, prove disabling while pointing to social, political, and legal barriers shaping individual lives. So let me begin by introducing you to Mr. Rogers. I use the honorific Mr. to grant him and others I discuss the respect that historians owe to people whose lives we explore. A 32-year-old unmarried clerk and Irish immigrant, Mr. Rogers came to the neurology dispensary in 1883 seeking help for depression and nervousness, which he ascribed to overwork. He was treated for neurasthenia. 2 years later, he returned and received a diagnosis of locomotor ataxia. Between visits, he'd begun feeling constrictions around his abdomen and had sciatic pains in his legs. He'd experienced gastric crises and had trouble buttoning his clothes. The doctor did not need Mr. Rogers' acknowledgments of a chancre 12 years earlier to make a diagnosis. The symptoms made it all too clear. Let me go back. Sorry. Mr. Rogers made at least 16 dispensary visits between 1885 and 1889. He received prescriptions for potassium iodide, a standard remedy that caused him digestive problems. He took mercury by inunction, another common treatment. This image says mercury inunction. It shows 3 advertising posters for mercury inunctions. One for lanolin mercury that you rub in, one for Eucerin that you can use to put a mercury ointment in, and one showing a man looking at himself in the mirror with wearing a chest pad for Merculent. Chest pad number 2 should be worn every year for 8 to 12 weeks as a prophylactic to prevent relapses. The doctor also prescribed Mr. Rogers strychnine sulfite as a tonic and medications to treat the side effects of other drugs. Horatio C. Wood, the clinical professor of neurology and author of Syphilis of the Nervous System, examined Mr. Rogers as he did some of the other dispensary patients. Wood occasionally overruled diagnoses made by clinicians and sometimes presented the patients to his students. In 1885, Hupp neurologist Francis Dercum arranged for Mr. Rogers and other patients to be photographed by Edward Muybridge for a study of pathological gaits. The images made visible the effects of a neurosyphilis infection, showing the difference between normal and abnormal locomotion. And these are images. The image says Mr. Rogers photographed by Muybridge. There are 2 images here. One shows a man just wearing a shirt walking. Another is multiple images, 24, I believe, of Mr. Rogers walking, being photographed step by step. Now, to place Mr. Rogers and millions like him into the history of disability is to see him as a working man experiencing a worsening, life-altering condition. People with neurosyphilis had pain and walked poorly or not at all. Their impairments included leaking bladders, obstructed bowels, headaches, mental confusion, vision problems, blindness, fatigue, hearing loss, impotency, and more. Some infected patients and their partners, some infected patients, some infected their partners and had children with congenital syphilis. Often people with primary and secondary syphilis could continue to work. Those with tertiary disease frequently could not, particularly in the later stages of the disease. This image says stages of syphilis, goes from infection to primary syphilis, chancre at the site of infection, secondary syphilis, rash, generalized lymphedema, and then latent syphilis with symptoms in up to 25% of individuals. 72% had no further complications. 28% went on to tertiary syphilis, including cardiovascular and neurological symptoms. For social critics, this made syphilis, this inability to work, an economic problem. For poor and working class individuals and their families, it was a household problem, threatening their self-sufficiency as well as their health. With the exception of few entries in the medical records, people with locomotor ataxia revealed little about their lives and struggles. It is challenging to learn if they were fearful or desperate when they sought help. and whether they were grateful, angry, frustrated, or confused by the care they received. Did dispensary clinicians treat them with scorn because of the source of their infections, or with disinterest because the disease, rather than the patient, was their concern? What kind of physical examinations did they undergo? Were they repeated on return visits? Excavating the emotions of people coping with disease and disability is challenging. Case notes are an inadequate substitute for direct testimony, but they are all we have. Working class individuals with syphilis did not leave diaries or memoirs. They had no charities formed specifically to assist them, and printing annual appeals studded with heart-wrenching accounts of their suffering. They are characters in narratives written by others at a time when their condition provoked disgust. Syphilitics, as they were called, were the undeserving sick. If disabled individuals were second-class citizens, people with evident syphilis were third-class citizens, impaired by their bacterial infections and disabled because of social and cultural taboos. We have numerous accounts of syphilis in interwoven narrative strands. One features moral reformers and discusses prostitution, the sexual double standard, and with the onset of World War I, keeping military men free of disease. This image says venereal disease and morality. It shows two images. One is the front piece of the Advocates of Moral Reform Family and Guardian. The other is an image of two legs with bound in chains. One says venereal disease, the other says enslaving habits, and the image asks, will you be a free man or chained? The moral stigma was such that accusing someone of having syphilis, also leprosy and plague, was considered defamatory and actionable under the law. Language mattered. When denying the claims of afflicted Civil War and Spanish-American War veterans, pension officials said their disabilities resulted from, quote, their own vicious habits. Viewing Mr. Rogers from this perspective, we would see him as an unmarried man who might have gone to a red light district and fornicated with prostitutes. We might ask if he was the offspring of degenerate parents. We would fear he could infect others and pass his dysgenic taint to future offspring. We would see him as a statistic and ignore his subjective experience as a person contending with pain, impairments, and a grim future. A second narrative resides in the medical literature on treatment. It too is threaded with moralistic assumptions. Despite efforts of some cultural and medical leaders to shift the conversation from behavior to public health, numerous texts indirectly underscored the idea that venereal disease signaled depravity. They offered veiled accounts of well-to-do private patients, obviously white medical professionals, afflicted due to their own ignorance and shocked to learn their diagnosis. In Fat and Blood, S. Weir Mitchell, considered the founder of American neurology, described a patient as a, quote, steady, sober merchant, closely confined by his business, always of excellent habits, with no possible suspicion of syphilis. Belief in innocent transmission was widespread, and not all cases of locomotor ataxia were therefore assumed to come from syphilis. This image says sources of innocent transmission and lists drinking glasses, knives, forks, spoons, cigars, pipes, glassmakers' blowpipes, musical instrument, and has an image of a pipe. Census reports and later a study of World War I draftees listed syphilis and locomotor ataxia diagnoses separately. Whatever its source, a syphilis diagnosis rendered disclosure a risk. For this reason, men found to have syphilis during an insurance exam could have their condition reported in confidence to the company so that their families did not discover their condition. In insurance nomenclature, people with syphilis had, quote, substandard lives. The 20th century brought vital medical breakthroughs: discovery of the Treponema palladium bacteria, diagnostic tools, the Wasserman and Noguchi tests, and the development of arsphenamine, salvarsan, as an effective chemotherapeutic treatment. This image says advances in medicine: Treponema palladium, 1905, Wasserman test, 1906, salvarsan, 1910. It has an image of a curled spirochete from the syphilis. It has an image of test tubes with varying amounts of blood in it. And it has a picture of a box labeled salvarsan and a vial labeled salvarsan. These scientific advances made a critical difference in the lives of some individuals with primary and secondary syphilis and drove a decline in deaths, debility, and congenital infections. To shine a light on medical advances is to investigate science, medicine, knowledge, and progress. To study individuals unable to access or benefit from the developments leads into the shadows and an entirely different story about disability, exclusion, pain, and death. Public health is a third narrative strand. 20th century estimates of syphilis hovered around 8%, although the condition was known to be severely underreported and to have higher rates in specific populations, such as military recruits. Classified as a, quote, loathsome disease, an infection meant automatic exclusion of would-be immigrants, although only people with signs of the disease were tested at ports of entry. State measures focused on preventing transmission included mandated premarital blood tests and eugenic sterilization laws. This image says 1936 public WPA poster: stamp out syphilis, every baby is entitled to be born healthy, blood test and examination should be made before marriage by your doctor. It's from the Bureau of Social Hygiene Clinic on Staten Island. 2 points are made on this image. Premarital blood testing would continue through the 20th century. 2019 was the year that the blood test requirement for marriage was finally abolished in all 50 states. Municipal officials often pressed for mandatory reporting laws, and here too, social class mattered. New York City health official Herman Biggs, for example, pushed for case reporting by institutions but exempted private physicians. He assumed that the, quote, poorer classes only took treatment to relieve symptoms or until treatment was interrupted by the need to earn a living. Biggs overlooked the fact that most dispensaries had workaday hours, making it difficult for patients to receive regular care. When patients returned after a long absence, necessitated by the need to earn a living, their declining health became evidence of their neglect, not of the limits of medicine. Physical barriers may have kept some people from returning for treatment. Locomotor ataxia made walking difficult. Navigating steps into buildings or to clinics on upper floors could be impossible. Rather than asking why patients did not seek care when first exposed or experiencing secondary symptoms, we need to question why some persisted in seeking help even as their condition worsened, despite the ministration of physicians. And one more point: there was no effective treatment until 1910. This image says Hospital of the University of Pennsylvania. It shows a very large multi-story building. It says hospital opens 1874, neurology dispensary opens 1875. So let's return to Mr. Rogers and to the Hupp Neurology Dispensary, where he first encountered a distinguished group of clinicians. Doctors there saw cases from 12:30 p.m. Monday through Saturday. They treated an average of 377 cases per year between 1875 and 1889, with the patient load increasing over time. I analyzed the records of people diagnosed with late-stage syphilis with motor symptoms, a locomotor ataxia diagnosis, or evidence suggestive of these conditions. For instance, Mrs. Hallenbach, a 35-year-old married woman diagnosed with neuralgia, a catch-all term for severe nerve pain, had painful joints, a red rash on her face, both signs of syphilis, and a husband hospitalized with syphilis. So I included her in my analysis. This image says patient records, neurological dispensary, shows an open book with unreadable, for purposes of privacy, handwriting of a patient record. Now, I want to be clear that people with syphilis receive care in 7 different Hupp dispensaries. All specialists at Hupp were familiar with the disease, even if it was a small part of their practice. Individuals with primary and secondary syphilis went to the venereal and genitourinary diseases dispensary. Neurology dispensary clinicians treated late-stage disease. Skin and eye clinic doctors treated people with specific symptoms, such as syphiloderma and syphilitic iritis. This is an image that says neurosyphilis, blindness, Argyll-Robertson pupil. It has a sign that says syphilis may cause heart trouble, blindness, deafness, mental disorders. It has an image of eye examination equipment, including some glasses, and a definition of Argyll-Robertson pupil, irregular, small pupil, light near dissociation, bilateral diseases, neurosyphilis, and Wernicke encephalopathy. A significant portion of late-stage neurosyphilis patients had vision loss. One Ohio charity observed that 12% of blindness cases came from acquired as opposed to congenital syphilis. Some patients postponed seeking treatment, probably because they had to work or felt they could cope on their own. Mr. Mensch, a 41-year-old white married telegraph operated, reported being out of work for, quote, 7 or 8 months prior to his appearance at Hupp. He told the doctor he experienced nervousness, a stopped-up feeling in his head, and catarrhal symptoms, acknowledging a syphilis infection 5 years earlier. The doctor prescribed potassium iodide. On a subsequent visit, he said he felt better. Mr. Thompson, a 34-year-old married Afro-Caribbean laborer, also reported nervousness, an inability to work, and a prior infection. He received the same prescription and one for potassium bromide, a sedative, on a second visit. Dispensary doctors appeared to follow a standard protocol, starting with iodides, sometimes followed by mercury, and then, as needed, drugs for pain and to treat the side effects of the other remedies. As Mr. Mensch's and Mr. Thompson's cases suggest, there were no readily observable racial differences in prescribing, although the data is too limited for a thorough comparison. This image says patients, Hupp Neurology Dispensary, March 78 to April 89. Incomplete records: white male 120, black male 7, white female 9. There are 2 images of bottles of iodine and mercury. There is no way to know, of course, if Black patients whose race was clearly noted received disparate treatment in terms of doctors' interactions with them, the thoroughness of the examinations, and how they learned about their diagnosis. Gender and immigration status also appear to have made no difference in prescribing practices. Few patients made return visits. Most appeared less than 4 times, and half of that group came only once. A few made multiple visits over several years, including people who returned for twice-weekly treatments with electric current to relieve pain and stimulate muscles. Mr. Frick, a 44-year-old, largely bedridden German immigrant cabinet maker, received 11 faradic, alternating current treatments, followed by 5 galvanic, pulse direct current treatments over the course of 4 months. This image says electrotherapy. It shows one box that has a couple of what looks like round batteries in it, and another a drawing of a man seated without a shirt on a chair. Another man seems to be applying some wires to his feet and is dressed in a coat, so presumably a doctor. The use of electricity, a popular therapy in homes as well as institutions, was ineffective but often used in medical treatment and a failed effort to reverse a disabling condition. Slightly over 50% of the male patients at HUP acknowledged a chancre or some other venereal infection. The women were not asked. Did patients reply honestly because venereal infections were not seen as particularly stigmatizing by the working class men making up the patient load? I suspect that was sometimes the case, and that historians' presumptions, shaped by their readings of moral reform in medical literature, led them to assume all were equally shamed by the diagnosis. I have no evidence yet. It is merely a hypothesis for now. Perhaps patients acknowledge prior infections because they wanted the doctors to know what to prescribe, or because the initial infection and secondary symptoms disappeared quickly, giving them so little trouble compared to other illnesses and injuries that brought them to the clinic. Mr. Bells, a 42-year-old married coal mine superintendent, received 5 wounds during his Civil War service. Maybe the chancre he had in 1861 was the least of his troubles, at least until the emergence of his neurosyphilis. He described a rapid decline from weighing 240 pounds and being, quote, one of the strongest men in the country, able to, quote, lift 750 pounds of dead weight of iron, to being a weak 153-pound man. One day he had a chill, then a fever. He took a mustard bath, but he could not return to work for a bit. Next, he noticed a strange feeling in his toes, followed by a weakening in his legs, and then symptoms throughout his body. Dr. Wood admitted him to the hospital and lectured on his case. Most HUP records offered little information about the patient's medical history and capture few details of their work and family lives. Mr. Bell's experience resembles many others, but the microhistory in his record gives a sense of a life before and after the disease was diagnosed. He was once a soldier and a strong man. He was the father of 8, a worker, and from a, quote, healthy, long-lived family. In an era when physical prowess, economic self-sufficiency, and productive labor equated with manhood, he was suddenly unable to fulfill his expected role in an economy centered on industrial capitalism. This image says patients, HUP, neurological dispensary. There's an advertisement there for Burnham soluble iodine, and it lists them by age. Under 21 case, possibly congenital. In the 20s, 28 cases, 30s, 49 cases, 40s, 35 cases, 50s, 16 cases, no data, 6 cases. As this shows, men in their prime working lives comprise the vast majority of dispensary patients. Most lived in Philadelphia and toiled in lower or lower middle class occupations, most frequently as laborers. Others worked in construction as bricklayers, carpenters, and stonemasons. Perhaps they built the institutions where they later sought care. A few had indoor jobs. Workplace hazards and exposures complicated their diagnoses. 30-year-old Mr. Sweeney's record said he had toxic tremor. He reported rubbing turpentine on wood for 6 weeks in a closed room. He acknowledged a daily drinking habit that had ceased 7 months earlier and a syphilis infection 13 years earlier. Which or how many of these accounted for his numbness, trembling, and nervous spells? Patients, probably correctly, perceived the workplace as the site where their health and livelihoods were most threatened. An ironic indication of their economic precarity can be seen in the delusions of two whose conditions progressed to paresis. A clerk imagined that someone had given him $25, a huge sum at a time when the average industrial wage amounted to $325 a year. A bookkeeper told his son that he, quote, need not work anymore, end quote. A life with money and without hard labor was an oxymoronic, rational delusion. This is an image of the Philadelphia Orthopedic and Infirmary for Nervous Diseases. It shows a multi-story corner building. It's a drawing illustrated with horses and buggies going by. So let's move 2 miles east from Hupp to a specialty hospital and into a period when medical breakthroughs in syphilis diagnosis and treatment began, and asked, what did it mean for patients disabled by neurosyphilis presenting as locomotor ataxia? Meet Mr. Roll. He was the son of German immigrants, employed first as a tanner while living with his family, and then as a shipping clerk for a wholesale druggist while living as a boarder. He arrived at the POH in 1914 and told the assistant physician taking his history that he had pain and, quote, a little difficulty walking, a common symptom of locomotor ataxia. I should note that some records use the more specific term tabes dorsalis, indicating degeneration of nerve cells and fibers carrying information to the brain and spinal cord. Mr. Roll was one of 267 patients in the locomotor ataxia ledgers who came to the dispensary between 1894 and 1917. He differed little from the majority in terms of age, race, and occupation, but was exceptional in continuing his visit for 11 years, and this was not the record. He, like most patients, came on his own. A few were referred by physicians, hospitals, or charities. Had they gone elsewhere, they might have seen the same clinicians. The POH neurologists were part of a local network of specialists and worked in many of the city's institutions. This is an image of S.W. Mitchell examining a patient at the Philadelphia Orthopedic Hospital. It shows a man in a suit with a beard, seated examining a man in short sleeves, and he's looked upon by other men in suits and women in nursing uniforms. Regarded as the first neurology hospital in the United States, the POH opened in 1867. There, clinicians operated on so-called crippled children and adults suffering from, quote, hunchback, hip disease, clubfoot, knock knees. In 1870, the hospital added an infirmary for nervous diseases, and soon adults with neurological problems dominated the caseload. Syphilis patients appeared in the neurological patient records, in the inpatient records, and in the locomotor ataxia volumes. As at the POH, syphilis cases constituted a small but consistent part of the patient population. In 1914, for example, there were 72 syphilis patients in the neurology ledger 18 in the locomotor ataxia volume, and in the outpatient neurasthenia cases, numbered 320. According to its bylaws, the POH served patients, quote, irrespective of creed or color, but the vast majority were like Mr. Roll, white and male. Others were listed as colored or by ethnicity, such as Hebrew, or by their country of birth. This image says locomotor ataxia cases, infirmary for nervous diseases, 1894 to 1917, white male, 229, black male, 6, white female, 30, black female, 2. This, of course, makes it impossible to do statistical comparisons for the most part. The case notes do not indicate disparities in treatment by race. However, the doctors paid close attention to this variable as medicine was suffused with racist assumptions grounded in supposed scientific arguments. POH clinician Charles W. Burr, a eugenicist, believed locomotor ataxia to be a rare disease among Negroes, that's his quote, although he called for more study. He and the other doctors made notes on mixed race individuals, always asking if they had any, quote, white blood. The record of a 40-year-old widowed housewife who received treatment for 18 months contained the observation that she was, quote, not a full-blooded negress. While racial thinking did not appear to determine prescribing practices, it clearly shaped how clinicians thought about disease, patients, and the medical questions they posed and attempted to answer. The Nervous Disease Clinic opened at noon on Mondays, Wednesdays, and Fridays. An assistant physician taking postgraduate training in neurology examined the patients and recorded the findings on a printed form. This says Record Philadelphia Orthopedic Hospital and shows a hard-to-read picture of the form where doctors took their notes. Under personal history, previous diseases was listed, then injuries, syphilis, habits, alcohol, tobacco, cause assigned by patient, age at onset, symptoms in order of succession. Doctors elicited all of this information about family history, medical history, social history, and symptoms. Only men were asked about alcohol and tobacco use. Women were sometimes questioned about coffee and tea consumption. And everyone was asked about the effects of climate on their condition. The physical examination yielded information about types of pain, locations of weakness, vision problems, and reflexes, particularly knee and ankle jerks. It isn't clear who wrote the notes or if patients saw the same doctor on return visits. Equally opaque, of course, were the ways patients experienced these encounters. After their initial examination, patients met with an attending physician, all of them elite neurologists who made major contributions through their research on patients. This image says physicians treating locomotor ataxia cases, Durkham 1 patient, Burr 13, J.K. Mitchell, son of S.W. Mitchell, 21, S.W. Mitchell, 41, Morris J. Lewis, 76, Wharton Sinkler, 88, and no information 4. Only S.W. Mitchell wrote about the locomotor ataxia cases he treated at the POH. Following his initial examination, Mr. Roll met with Morris J. Lewis, the attending physician in the dispensary that day. And Lewis had little trouble diagnosing him because Mr. Roll exhibited the classic symptoms, quote, deep or superficial pain, lost knee jerk, and Argyll-Robertson pupil. Lewis possessed one other critical piece of data. When asked about syphilis, Mr. Roll answered 1904. A Wasserman test subsequently confirmed the diagnosis. While patients often acknowledge prior infections, when asked about the source of their problem, they frequently pinpointed recent traumas, perhaps because their chancres had resolved on their own. One man blamed his difficulties on removal of a corn 3 years earlier. Another attributed his physical difficulties to bicycling. A 44-year-old plasterer told the doctor he had gonorrhea 8 or 9 years earlier, but assumed the source of his complaint to be masturbation. Fundamentally, what mattered to these individuals was not the source of their problem, but their physical limitations. Starting in 1906, the POH pathologist and bacteriologist administered Wassermann and later Noguchi tests. The results appeared in the patient's record in bright red ink. The tests were hardly diagnostic for individuals with obvious signs of late-stage disease. They did impose new costs on the institution and on patients who were determined able to pay. Charges for treatment in 1914, for example, hydrotherapy, $1, massage 50 cents, electricity 50 cents, gymnastic exercises 50 cents, a Wassermann test for hospital private room $5, dispensary $2, Neosalvarsan or Salvarsan, hospital private room $5, dispensary $2. For new infections, of course, the tests enable doctors to treat these recent infections and aided public health authorities in data gathering and case tracing. Once Salvarsan treatment became available and could be administered early in infection, the tests had even greater value. Patients with tertiary syphilis were no longer contagious, and while Salvarsan could halt the progress of their disease, it could not reverse the damage already done to their brains and spinal cords. This was the case with Mr. Roll. Not surprisingly, in 1918, at age 40, his draft registration card listed him as having a disability in his right and left legs. Despite his physical challenges, he continued to work. The 1920 census recorded him as a ball maker, and in his medical record it said he could, quote, stitch 42 league balls a day, presumably at the Reach Baseball Factory. This image says Reach Baseball Manufactory, workplace of Mr. Roll, and shows a large multi-story building. Mr. Roll seems to have held that job for a few years and to have made enough money so that by a 1925 entry, it noted a 3-week vacation at the shore. Like Mr. Roll, a majority of the patients, 56%, acknowledged syphilis infections, typically by recalling the year of their chancre or the time elapsed since then. This image says patients, Philadelphia Orthopedic Hospital Dispensary, under VD history, admissions, 147 or 60%, denials, 48 or 19%, no information, 49, 20%. And I note that fewer patients were asked after Wassermann test became standard. The age of patients, again, under 35 patients, 30 to 39, 59 patients, 40 to 49, 107 patients, 50 to 59, 52 patients, 60 plus, 9 patients, no information, 12 patients. Worth noting, I think, is the extent of patient knowledge, while also observing that some confused gonorrhea and syphilis or offered incorrect assessments of the cause of their condition. A few reported treating themselves, most likely with products containing mercury or potassium iodide, and sold over the counter. Some obtained prescriptions at other dispensaries or from doctors or alternative providers. This image shows some advertisements for locomotor ataxia treatments. One says, cured patients, Adkin Vitopathic treatment. Another is for Dr. H. Sanchez Oxydonor. which stimulates the mind, gives good appetite, cures nervous prostration, and among the list of things, locomotor ataxia. One man reported to the POH taking bioplasm, a product that was heavily advertised as a cure for ataxia. Mr. Roll's record said that he had, quote, been treated with one bottle of medicine and told he would be all right, end quote. While access to care during working hours may have been limited for many patients, their self-treatment and drug purchases showed them as engaged healthcare consumers in a thriving and competitive medical marketplace. For Mr. Roll, Dr. Lewis initially prescribed mercury by inunction at night and sodium iodide 3 times a day, which caused long episodes of diarrhea, a sometimes disabling condition that, like other medication side effects, is little discussed. Mr. Roll later received injections of salvarsanase serum, which was first given to a locomotor ataxia patient at the POH in 1911. And then Mr. Roll later took intraspinal mercurialized serum. During his extended treatment, he had 10 Wassermann tests, most of them blood tests rather than the more painful spinal tests. He often reported feeling better, and his record had entries such as, quote, doing well and, quote, walking better, along with notes on weight gain and the return of his sexual power, despite his initial claim that it was intact. However, his health never improved. It simply ceased to get worse after he began taking what the notes called 606. As late as November 1921, his stance was still bad, and his record noted that he would, quote, would fall if his feet were even a foot apart. 8 years after his first visit, he finally had a negative Wassermann test and later a second one. Salvarsan ended his infection. His visits continued for several more years, because his pains persisted. He continued to be prescribed mercury and iodides as well as aspirin, a remedy that many patients reported as supplying relief. And then he disappeared from the POH and from public records. Just as there is no way to know why he started seeking care, there is no way to know why his visits ended. Assistant clinicians worked at the POH to learn neurology. Senior physicians saw clinic duty as a service, a moral obligation, and an opportunity to learn, to experiment, and to find material for publications and addresses. Their work was at once charitable and exploitive, and potentially of service to medical science. S.W. Mitchell voiced his opinion of the patients when he warned in lectures to students not to become hardened to, quote, the exposures and pains and suffering of the clinic and the ward. He called his dispensary service, quote, long and tiresome, and the work, quote, an acute test of character. Despite what Mitchell and others undoubtedly perceived as the trials of treating poor clinic patients, they did attend to them beyond ordering diagnostic tests and prescribing standard remedies. And they did so to good effect. The highly choreographed medical encounter can be likened to a complex folk healing ritual. Begun by assistants, moving to a face-to-face meeting with the expert, the big man, and concluding with the naming of the remedy. The power of medicine in this encounter came from professional authority and in the professional setting, but it provided no cure. The performance included probing patients' lived experiences, and that seemed to have a salutary effect, if the reports in the records are to be believed. Mitchell, in particular, made a point of asking patients at every visit about their sleep, appetite, and bowels. He and the others prescribed iron tonics for weakness, laxatives and diuretics for those whose spinal cords left them with bowel and urinary problems, sleep remedies for those unable to rest, and most importantly, drugs for pain, phenacetin, aspirin, cannabis indica, and morphine. None of the medications altered the course of the disease. Each hopefully made living with the symptoms somewhat easier, and may explain why patients made return visits and had entries such as "feels better" in their records. A substantial treatment in non-pharmaceutical restorative measures and physical therapies distinguished the POH from other institutions. S.W. Mitchell, a proponent of electricity and massage for many conditions, prescribed it often. The POH staff included a medical electrotherapist and others who oversaw educational exercises in the hospital's gymnasium. This is a picture labeled gymnasium. It shows a man leaning against a device, another man with his back arched lying on a table, and some rings hanging from the ceiling. Nurses who enrolled in the POH training school received instruction in electricity and massage, and eventually were taught in a 3-month training course open to individuals seeking careers in these fields. J.K. Mitchell authored publications on mechanotherapy and massage and served as an instructor in the course. Not coincidentally, the tuition payments aided the hospital's bottom line. Between 1896 and 1905, doctors Lewis, Sinkler, and Mitchell embraced a cutting-edge treatment for locomotor ataxia: administration of Brown-Séquard testicular fluid. Articles in the Lancet in 1893 and 1894 deemed it ineffective. However, a summary of foreign case reports published in the New York Therapeutic Review reported numerous cures. This is a advertisement, picture of an advertisement. It says testicular extract for locomotor ataxia, extracts of animal organs, and testicular extract was $2.50 for one vial. The review was published by the New York City Pasteur Institute, the home of the Biological and Vaccinal Institute of the Pasteur Institute, and that, not coincidentally, sold the extracts. Mitchell, a longtime friend and correspondent of Brown-Séquard, was initially skeptical of what he called testicular elixir, but after using it concluded that, quote, whether a physical basis can reasonably be assumed, we have in this fluid a tonic remedy of great power. At least 14 dispensary patients diagnosed with locomotor ataxia, including one white woman and one African-American man, received this tonic. Testicular fluid did not, in fact, have any Brown-Séquard testicular fluid did not, in fact, have any effect on either the syphilis bacteria or the patient's physical condition. It did, however, have documented placebo effects. Mr. Campbell, a 55-year-old married stonecutter, reported sleeping better and experiencing less pain only 2 weeks after being prescribed potassium iodide. And he subsequently reported that 3 times a week injections of Brown-Séquard fluid into his buttocks produced an immediate improvement in his ability to walk. He skipped the injections for a week, felt worse, and resumed the injections and soon felt better. Similarly, positive reports came from Mr. Wheeler, a 43-year-old married African-American barber, prescribed cod liver oil, mercury, and potassium iodide, in addition to thrice weekly injections. Perhaps acknowledging its limited effectiveness, Mr. Wheeler's record indicates that his physician, S.W. Mitchell, regarded its effects as, quote, mental. Mitchell nonetheless continued to prescribe the injections, noting after a year they had begun that they, quote, made no difference if admitted. Mitchell nevertheless arranged for Mr. Wheeler to give himself the injections. They continued, so of course did the disease. Were the POH clinicians practicing patient-centered care or medical experimentation? Probably both. Were the various interventions consensual? We have no way of knowing. As elite neurologists, POH doctors kept abreast of the medical literature and contributed to it in part by testing out treatments on their patients and publishing the results. Confronting patients with locomotor ataxia, their findings amounted to learning what did not work. None of the people treated for tertiary syphilis at the POH or at HUP regained their health. None overcame the substantial impairments limiting their lives and threatening their economic independence. Some ended their days in the wards of the city's charity hospital. So we can acknowledge the sea change in medical diagnostics and therapeutics for syphilis, but we need to also pay attention to the people left floundering and drowning in the shoals. Their disease was neurosyphilis. Their pain and their physical and mental limitations, the things they lived with, rendered them disabled. So where does Mr. Roll's history and that of others like him belong? For medical historians, his long years of treatment demonstrate the use of new diagnostic tools and therapies. He became a patient on the threshold of great change, but he never fully crossed it. His life may well have been saved by Salvarsan, but his impairments remained. For disability historians, Mr. Roll's life demonstrates how late-stage syphilis led to permanent impairments at a time when the diagnosis was unspoken in good company and was socially as well as physically handicapping. Over time, patients' medical experiences changed. The social stigmatization and the legal barriers remain. There were millions of people like Mr. Roll, yet individuals who shared his diagnosis received little, if any, attention from disability scholars. We can easily access the literature about babies blinded by congenital syphilis and present it as tragic and pitiful symbols of the need to eradicate the disease by educating the public. We find little about adults blinded by syphilis or disabled in other ways, and certainly they received no public sympathy. And yes, of course, we meet this story again and again, most recently during the onset of the HIV epidemic. Ultimately, my point is a simple one. As historians, we need to enlarge the narrative and move beyond the extensive medical and moral reform literature to put more patient lives at the center of our histories of syphilis, as we did when writing about HIV. We need to try and uncover the experience of poor and working class individuals of all races suffering with syphilis before treatments became available. Doing so lets us collect the health history disparity that has told us more about what well-positioned experts thought than about what people struggling with the condition felt and lived in the years between the Civil War and World War I. And another point, as historians of disability, we need to incorporate the lives of those whose impairments stem from what contemporaries viewed as bad or immoral behavior. Their impairments resemble the conditions of others who are blind, deaf, crippled, and disfigured, yet they do not appear in our histories. Finally, a last point. I want to turn back and acknowledge my subjects, Mr. Rogers, Mr. Roll, and the others I named. Thanks to their health seeking and to the archivists who have kept their records, they have left us a legacy and endowed us with a greater understanding of the past. Thank you. And now a brief coda for those of you watching the video. And it's a question I hope to be answering at the talk. How did I, a 20th century historian focused largely on the health encounters of women and children, come to write about men diagnosed with syphilis in the late 19th and early 20th century? The short answer is my students. Decades ago, I took my graduate students to the College of Physicians, where Ed Moorman opened up the patient records from the POH. Each student had to learn everything possible about the patient, the doctor, and the disease as it was understood at the time. They wrote fabulous papers, and it made me want to use those records. Then the late Larry McHenry, a neurologist and historian of neurology, asked me to review a grant application he had written to write the history of the institution. Unfortunately, he died before he could submit it, and that application has served as a guide for me. Finally, my undergraduate students in my history of American healthcare, none of whom were history or science majors, and who took my class because it fulfilled a humanities requirement and met at the right time of day, they reminded me of how much they like to learn by reading about individual lives. With that in mind, I thought after I retired, I would write a history of 20th century healthcare from the germ theory through HIV, centered on patients' lives. And I would begin with an infectious disease. And so I turned to the syphilis patients at the POH. I thought I'd just place the patient records into the literature on sex, moral reform, science, and medicine. Instead, the material commanded that I write about disability and patient lives. Once again, thank you.